My name is Natasha Yusta. I am the Global Director for MIS and Foot and Ankle Solutions for Enovis. Really excited to be here tonight and very excited to have Dr. Amiethab Aiyer to join us and lead us in this great discussion on Wires First. He is an orthopedic surgeon and division chief of foot and ankle surgery at Johns Hopkins University, where he specializes in advanced techniques for treating fractures, deformities, and tendon and ligament injuries. He's a leader in the minimally invasive space, and we're very proud and excited to have him here. So thank you so much for doing this with us today.
Thanks, Natasha, for that warm intro. And thank you to Foot Innovate for hosting this. And I'll share some additional thank yous in just a minute. And above all else, thank you to all of you for listening tonight. I know it's late, at least a little bit late on the East Coast and 8 o'clock. And so thanks for taking an hour out of your day to kind of go over this and something very interesting, very unique called Winning Fast with Wires First, really an evolution of minimally invasive Hallux valgus surgery. If I can get this to work, I'm going to set my timer and share some relevant disclosures. And important to know, I am a paid consultant and the minimally invasive surgery advisory board member for Enovis. So that's important to highlight as it's related to this talk in particular. And as it relates to this talk, furthermore, I am a Taylor Swift fan, courtesy of my wife, for better or for worse. And these are my kids, well, 2 of them anyway, at the recent release party for one of her albums. I do want to again just really extend a thank you, a grateful thank you to Foot Innovate and Enovis for the opportunity. Again, to all of you for being here, and special thanks to some of my colleagues. I really need to give a huge thanks to my family. My parents are actually in town visiting for my daughter's birthday, who just turned 5. She turned 5 yesterday. So it's really amazing to have my folks here in town. My dad is actually listening. And I do need to give a special shout to both Innovate and Valor Medical, with whom I've been able to collaborate on this. Several of the people listed here, photographed here, have been instrumental, no pun intended, in making this project come to life. And finally, above all else, to the Surgeon Advisory Board, both domestically as well as globally. I cannot thank you enough for really welcoming me into this team and being able to collaborate on a day-to-day basis with cases, concepts, ideas, and really navigate this terrain with you. Being up on this particular stage back in Savannah at the AOFAS meeting was a huge honor. So I really just need to share that as well. So I just want to talk a little bit about background, right? We know Hallux valgus is common and shoe wear plays a role. And there's obviously there's been studied to be a genetic predisposition, and there's hypermobility concerns, and flat feet may be accompanied by this too. And that's something that you have to be thoughtful of. And we know that this also is affected not just by age, but also gender predominance, of females be affected more commonly. And we have to think about the anatomy and the etiology. And why this is important is because when we think about how to go from the open approach to what we now think of as minimally invasive approaches for treating Hallux valgus, soft tissue envelope and the anatomy there becomes important, right? So there's almost this subluxation medially with loss of the, capsular or attenuation of the capsular structures, a plantar migration of the abductor, and a contracture of the lateral joint. And as a result, the various soft tissue balancing structures are not working as ideally. And you end up getting not only a destabilization of the sesamoids, but you get an accentuation of deformities in part by the AHL as an example. And the adductor, the adductor and its attachment at the proximal phalanx really represents sort of another deforming force as well, and something to think about. So when we think about severity, right, and this is sort of what's dictated treatment for years and years, especially from an operative standpoint, we think about these various angles. And there's been inconsistency in the literature as far as how well we measure the articular surface angle. But nonetheless, this becomes important in thinking about how you might treat any of these patients. And of course, if you're hopefully fan of the Freshmen of Bel Air, like I am still to this day, the reality is that non-operative is obviously the first line of treatment, and something I still offer to patients because not everyone's ready for surgery. But then, of course, when shoe modifications, therapy elements, anti-inflammatories, toe spacers, whatever gizmo they're finding on the gram or Amazon or thereafter, when that fails and isn't working, then of course operative treatment becomes important. And so historically, we've thought about these various approaches from really the severity of the deformity, right? That's why, that's what's driven, hey, I might pick a certain approach in part based on what the radiographic parameters in the context of the patient's sort of clinical deformity may look like, and obviously make a decision as to what may be the best option for the patient. But we know that open approaches are, have their own set of complications, right? In, some studies, it's as high, recurrence rates are as high as 10%, sometimes higher. In this, systematic, lit review, it was about a 5%, recurrence rate. Of course, we think about, malunion phenomenon, especially with, tarsometatarsal arthrodesis procedures, non-union, also in those fusion procedures as well. And these are important considerations, right? Now, again, this is sort of one, kind of study looking at, several other ones, but it's important to really consider these. And this is not even taken into account this is not even really taking into account some of the, stripping of the soft tissues, potential risk for avascular necrosis, although somewhat debunked, prior, studies for distal osteotomies. But these are things that have to be, kind of mentioned and thought of when you're considering an open approach. So how do we get around this, right? How do we think, about additional approaches or new way of approaching this? Really, what more do you need? And this really strikes me as the fate of open surgery, right? Like, are we able to sort of pivot away from some of the risk factors that open surgery or open approach to bunions really provide or afford, and can we try to minimize that to the best of our ability? And that's where minimally invasive correction becomes particularly important as a whole. And so what is minimally invasive surgery, right? Just taking it from sort of a top level, it's a surgical philosophy. We are trying to minimize, the soft tissue insult to accomplish a desired result, right? And so incisions are one part of it, but there's a lot more, as we'll dig into in just, in just a few minutes. And I want to be very clear that minimally invasive surgery is sort of like a broad stroke sort of terminology, right? But it's really the thought process by which we try to sort of afford, more increasing amount of correction for whatever the type of deformity correction that's, being undertaken, with smaller and smaller soft tissue disrupting incisions as a whole. So, this is a slide from, from one of my colleagues, Brad Abicht, and I think it's really important to recognize that the learning curve is, I think, what often, and especially what I've observed, is what holds people back, from exploring something, right? Adoption of new technologies is not, a route without its own set of challenges as you're figuring things out. But, how do you go from sort of using this, Shannon burr, as, reported here, to now these types of smaller incisions versus what people have been historically afraid of, undergoing from a patient perspective, which is much larger incisions as a whole. And I think that that's where, reproducibility of surgical techniques, one person does it this way based on the course you went to, another person does it this way. And while there are nuances and you've got to figure out what works in your hands, if we can make it more reproducible as a whole, then that is something that helps to ease the adoption learning curve also. So why do you consider MIS, right? And I think it's an important, when you're making that, that pivot, it's an important inflection point because it's a different way of thinking about things. And it's important to sort of think about, well, what are the advantages? How is it going to benefit the patients that I'm taking care of? But we've also seen, right? They used to do ACL reconstructions open. Many people used to do predominantly open rotator cuff surgery. And now it's, many times are mostly arthroscopic. So many surgical types move in that direction. And especially as it relates to the bunion, we're thinking about less pain, less stiffness, wound complication rates are lower. And even in some recent studies, hey, return to work is a little bit faster. The amount of oxycodone or narcotic consumption is also minimal as well, especially in the first week or so after surgery. And really, without getting into the weeds of some of the biology or biochemistry, the reality is that we are trying to preserve the periosteum and the robust soft tissue envelope and the vascularity as a whole. And so when I think about this, I think, never mind the growth factors that are, listed here and, sort of the, various inflammatory factors that we have to be thoughtful of, we want to try to sort of progress along this, bone healing pathway or a secondary healing pathway of, hey, we go from, inflammatory cascade to a hematoma to then evolving to a soft and then a harder callus, and then allow for healing across a non-operatively treated injury, as in this case. And as in pediatric population, we know that the stiffness of any, and just as a whole, the stiffness of a cylinder is proportional to the radius to the fourth. And yes, Dad, I still do remember that engineering principle. So if you notice how this, particular proximal humerus is evolving over time, the callus is ballooning outward to afford more stiffness because of how thick that periosteum is in this particular patient, and in a pediatric patient for that matter. So how does this differ from an adult? In an adult, your periosteum is much thinner. You don't have the same luxury of a rubber shell of a periosteum that can really guide the healing process, but you do have soft tissue, whether it be a large soft tissue envelope or a smaller soft tissue envelope, and that is something that you have to be, mindful of as well, as we're moving forward. So ultimately, preserving the soft tissue envelope, preserving the vascularity are really the tenets of, minimally invasive bunion correction or Hallux valgus correction, and the goals are the same. Right, we want to not only preserve that sort of soft tissue envelope and sort of take advantage of the blood supply and healing capabilities when we do that, and not strip the tissues, but ultimately we want to improve all the angular measurements. Some folks obviously believe in the position of the sesamoid station robustly from a rotational perspective. Obviously, there's data that kind of goes back and forth on the value of that, but ultimately we're thinking about the patient at the end of the day, right? That's the value of minimally invasive surgery. It is shortened procedure time. It is decreased risk for infection. And I would say, I personally, will share a little bit more detail later about what my postoperative protocols are and so on, but I have patients walk on that pretty darn quick. And in trying this technique, going back a few years now, I would literally take, or the former version of the technique, I should say, I would take the cadaveric specimens and just bang them on the table and not see anything move, and just get a feel for how stable that this construct or these constructs are, and way more cosmetically appealing as well for patients, especially back in Miami, where I was being asked about the cosmesis of it all on a frequent basis. So what are our indications, right? I would say that whether it's mild, moderate, or even severe, and there's now data that sort of supports the utility of this in even severe cases. I think that you have to also feel comfortable with what you're doing. Whereas we, folks in, at least domestically, may think about, hey, progressing with, for a super wide IMA, and we're concerned for anatomical differences at the tarsometatarsal joint, maybe consider a lapidus. This same, in the hands of some of our, European counterparts, might consider still a minimally invasive correction, just as we're going to describe in a few minutes for that same patient. So I think ultimately it is about what you feel that you can afford the patient safely, and ultimately help reduce the risk of complications thereafter. So how has this sort of evolved, right? There was the original sort of techniques of, sort of these intra-articular osteotomies of the head where, really nothing was done. And then there was a transverse osteotomy with a K-wire that was put into the canal to help displace the head medially to facilitate correction. And then, of course, the third generation which was introduced by, David Redfern and Joel Benoit a handful of years ago now, really popularized in the US anyway, by them. That really was a chevron type osteotomy using, kind of AO based fixation. And now, as things have gone to really the fourth generation of more of a transverse osteotomy, with plus minus a proximal phalanx osteotomy as well. And again, similar fixation, which is non-differentially pitched headless screws that help to stabilize osteotomies where they are, without inadvertent shortening of the metatarsal in particular. And so just to go through some of these, some of these prior techniques, this is sort of your initial osteotomy, your generation 1. This is really your generation 2, not my case specifically. And this is really that, generation 3, but some of the generation 3 and 4 x-rays look, markedly similar. But whether you choose to do an Aiken osteotomy along with this or not, it's really, dealer's choice. Although for myself personally, I tend to do an Aiken for everybody, but that's something to keep in mind as well. I think that it's also important, what else do you have to be mindful of with the Hallux valgus that's presenting to you? What's the clinical appearance like? Is it a primary case? Is it a revision case? To what extent, how invasive do you want to be? Do you feel comfortable with? Do you feel like you can get the correction? What is your procedure of choice? Of course, hey, to what extent are the toes, touching one another when you've made your correction? Do you need to shift the head a little bit further? Do you need to take a little bit more of a medial wedge with your Aiken osteotomy? These are all important things as well. And, I would say that it's become easier and easier to sort of make these decisions as you get skilled with it, but early on it can be very daunting. And that's in part what we're going to sort of transition to in a little bit, is what else can you do to make it easier for yourself? And that's where a transverse osteotomy allows for a little bit of a greater shift, a little bit better rotational control of the metatarsal head specifically, and still allows you to get those sort of bicortical fixation screws, especially with that proximal screw being sort of anecdotally reported to be as important, and even with more recent data showing with finite element modeling, showing that bicortical proximal screw is perhaps one of the most important tenets to minimally invasive Hallux valgus surgery. So these are things that we have to really think about as we're navigating through this, whether you're starting fresh out or you're moving your way into sort of the depths of a very complicated revision case, as it were. And so how do I move forward through this? So I naturally, obviously, my exam in clinic, and then talking to the patient about what the options are based upon the x-rays and based on the clinical exam findings. And then, of course, once I'm actually in there, they've consented for this Hallux valgus minimally invasive correction. As described here, I usually do the osteotomy first. I'll get the screws in, then I'll do an Aiken osteotomy, and then lateral soft tissue release to sort of make it easier for those sesamoids to come around if I feel it's absolutely necessary, or if I feel that there's still some incongruity to the joint, as it were. And I would tell you that the amount of times I've actually had to do that lateral release has gone down and down over course of the last several years. And so what is this learning curve, right? I get asked that all the time. I'm sure many on the call who do this routinely do as well. And in one study out from South Carolina that recently came out, they described, of course, like, hey, how one surgeon and another surgeon sort of decreased their time over the course of a couple of years, back in 21 to 23. But there was no sort of significant increase in complication risk, and the surgical efficiency just improved with experience. And the sort of learning profile, safety profile, all were, sort of within reason. And that's probably one of the most important things that people worry about. When I showed some of the x-rays to my chair here in Baltimore, and he just cannot sort of get his head around how this healing process occurs, or how I get the shift, or how I get the alignment. And it is something to really you have to sort of have faith in the process, understand the concepts behind it, understand the biology and sort of what we're trying to accomplish, and of course, watch the x-rays progress over time. This was sort of another case that came out, and it said that the operative efficiency is sort of plateaued after almost 40 cases, between 27 and 40. But of course, early on, when you're still filling things out, when you're still trying to figure out how to get the wires in place and so on, that can add to not only the OR time, but obviously fluoroscopy. And especially in those early cases, you're probably using a lot more x-ray just to make sure you're getting the right shots. And another thing that I would tell you that plays a huge role into it, that maybe some of these studies don't allude to, is just the positioning, right? Making sure you have your positioning as down to a T as you can when you're going into this certainly makes it a lot easier, but it's not something that's always discussed in these studies nearly as much. There was another study that came out, including one of our SAB board members for the MIS team, Dr. Chapman, and or Carrie Chapman, and we are, they define radiographically as two cortical bridges. And of course, they had, the displacement of the head had no real impact on this. So you can shift the head pretty significantly. And, one of my colleagues who went to science, Dr. Brad Abek from Wisconsin, he certainly, we always talk about how, we get the Brad 100 because he's shifting that head 100, just about 100%, if not 100%. And his x-rays look, we comment all the time, just literally textbook. And it's pretty impressive how he's doing that. And I would say that, can you shift it that much? Can the soft tissues tolerate that? And I would say, yeah, even in the cases I have done, I've gone to that sort of Brad 100 level. I can definitely see the healing take place over time and have not had any overall worry. And it's great to see that this study is justifying that. So when we think about this fourth generation, right, there is sort of this overall, we're going to shift the head. We're going to create this sort of level of stress. We're going to look at this triangle, and I'm going to refer to it as the, Dr. Abick triangle, in part because we know as there's stress, this is sort of the whole periosteal soft tissue envelope is getting sort of really stretched out at this level. And even in their study cadaveric studies that they've done, they've shown that, hey, there is increased healing. This is an area that's rich in vascularity. And that is something that we can really take advantage of, knowing how this heals at sort of a basic science level. But it doesn't matter whether you use 2 screws, 1 screw, whatever configuration. And even though I didn't cite the study specifically, our studies themselves, a study I did, with, a handful of years ago with, a couple of my colleagues, George Acevedo down from Florida, we found that it didn't really matter, it didn't really matter whether you were sort of bicortical or not, at least in terms of chevron versus transverse osteotomy. I would tell you that while those were non-Hallux valgus samples and we shifted the head and we tried to get bicortical on that proximal screw, I do think from a stabilization perspective and from even a clinical implication perspective, we do have to be mindful of the fact that, yeah, that proximal screw is important. And this finite element study I mentioned earlier definitely shows sort of like, hey, this is what's going to be, important to optimizing success in this type of surgery. But we also recognize, right, that again, like we've been talking, right, that these studies, like, MIS versus open, like, hey, like in this particular review, there is, they have similar outcomes, outcomes in terms of radiographic ones, but they have a faster recovery, but it has a steeper learning curve, right? So it is not as easy as it seems. And for everyone who gets the Taylor Swift reference, you're welcome. For those of you who do not, no worries about it. And I apologize ahead of time for my love of it. The reality is that there's now multiple studies, especially across 3rd generation and now increasing with 4th generation, showing the value, especially in comparison to open surgeries, particularly open scarf or open chevron, and even some comparisons to Lapidus as well, all of which are important to conceive of and understand. And specifically in this study out of HSS, they looked at 41 patients in either one open chevron and then 1 MIS. And the radiographic correction was appropriate. They were appropriate on the functional comparison side, and really the number of complications in open were, higher than MIS as we might, but they didn't really do a statistically significant comparative study on that with their data. And we also know, one of the biggest things that patients will ask, no matter what type of bunion surgery it is the recurrence. Will it come back? And we can see, at least in this more recent study by David Gordon and his team, really the recurrence rate is under 1%. And this is, again, 2-year follow-up, but there's, I think some additional more recent data that says it's, about that even further out. So really, how do we treat this? And, is it actually romantic that you're still thinking about open surgery? Yes, for those of you who get the reference, you do. And, I would tell you that for many, we have many patients who would probably tell me that, okay, I'm going to do, or many, docs would say, I'm going to do my open chevron, or I'm going to do a Lapidus because that's what I'm used to. I'm going to get that correction shifted. And I think it's important to think about what about it is easy and what about it's hard. I think perhaps the hardest thing is making the decision to actually just do it and really just adopt that, as a whole, and say, hey, listen, I'm going to commit and I'm going to move forward with this. And so let's just assume for a second that we've gone ahead and we've kind of decided to move forward into, hey, like an MIS case. And what does that setup look like? Because that, I think, is another thing that's hard. And so this is my setup, believe it or not, and it works relatively well for me. What I like to do is I actually like to take the down leg and sort of flex it up either with a stack of giant blankets, and my surgical center loves me when I do this, or I do it with a thigh holder, like an arthroscopic thigh holder, to get it out of the way. And it makes it easier to get the wires in and so on. So your hand is not hitting the other foot by accident. And then I will, kind of have the patient brought down ahead of that, down leg action, and then I will go ahead and put a stack of blankets underneath that operative leg. So that way it's easy to get the AP and the lateral as well. And this is really what it eventually looks like, right? And so we've got not only and thanks Brad for this particular slide. But you can see not only the alignment of the hallux, you can see the incisions medially, you can see the the presence of the screws. Both screws here are bicortical, and there's obviously closure of that osteotomy of the phalanx, and pretty much, like I said before, pretty much the Brad 100 near perfect X-rays. And we'll talk about sort of that residual spike and how to address that in a second, especially using some of our newer techniques. So in this fourth generation, right, we have historically put the wires, we have, for some folks, do osteotomy. Sometimes you get a wire in, do your osteotomy, and I'll kind of skip through this video as well of me doing the osteotomy itself. And I pretty much will advance, make sure I like the wire in all planes, advance it a little bit, shove the reduction tool into the canal that comes on the Enovis, Enovis Pecaplasty set. And that usually, the rounded portion of it that you can see here will effectively, nicely displace the head, especially if you go up from the medium-sized reduction wire to the larger size one, and shift that head into, displace it quite significantly laterally, and then you can rotate through the toe in order to get that sesamoid station optimized as well at the same time. And once that has occurred, and I still am a little bit timid about the Brad 100 and that 100% display, so I usually get to about 90, 95, and then put in my other wire, and then of course drill and put in these Pica 2.0 screws, which are differentially pitched, or non-differentially pitched, excuse me, have a 1.6 millimeter K wire cannulation and a 3.2 millimeter drill bit. And this is, ultimately sort of what this looks like once I get the Aiken going, and this is what it looks like at the end. And of course, you can see the sort of the alignment, as it were, the incisions that are there. And if I even play this video, you can actually even see the range of motion that it affords, which I try to get patients to start doing, as quickly as possible, as it were. And that's an important tenet to the recovery of this procedure as well. So here are some of the cases that I've done, as a whole. And I'll tell you, so this is one case I've done, with the technique I just showed you. Okay, great. These people are happy. They're some of my most content patients. I would tell you the bevel on this one right here could probably be turned one more turn, but we'll ignore that for the moment. But can we make this simpler? And can we make this more user-friendly? And I think that's really the question at hand. And so what are the biggest pain points, right? What is on your wish list, as it were? And I would say that, of course, having a really reproducible setup, I would put out there as one important thing. I would also say that it took me a while to get very comfortable with the wires and the wire placement. And that to me was probably one of the things I struggled with for a long time. And that is something that I think that, many of us who do this on the regular have said, okay, how do we make this easier, right? Some systems use a really skinny wire, something underneath like a 1/4, and that can cause deflection off the cortices when you're trying to get it across into the displaced metatarsal head. And then of course you have some systems where, hey, you've got a jig, but there's maybe multiple other wires that may make it hard to actually get the wires in place, or harder, as it were. And so it really is, how do you simplify this element? And this is where the wires first piece comes into play, and something that's predictable as a whole, that's simple to apply to the patient. We'll go over that in just a minute, and I'll show you some cases, as far as how I've used it to date, and I'm excited and honored to be a part of this team that's helping to bring this to life. So I'm going to turn this video on, and unfortunately the sound's not working, but I will effectively talk over what the guide looks like, as it were. And so it comes in this set, and the guide itself is, for the most part, made out of, carbon fiber. And the nice thing about the actual, about it is there's very limited instrumentation in there. So there's the actual guide, which, I'll pull out here in just a hot minute, as you'll see. There is an olive wire over which the guide will actually slide onto. There is an aiming arm that will allow you to actually bring the arms to near the base of the first metatarsal, so you can get wires situated at the level of the condylar flare. And then of course there are there are multiple sleeves to allow for, your 1.6 millimeter K wires, in order to get that situated first. And so the idea behind the olive wire specifically, which that knob I'm twisting now allows you to effectively kind of hold the guide onto, the olive wire is set into the metatarsal head, and the olive wire itself, which we'll show that in a minute also, is a 2.0 millimeter olive wire that goes into the metatarsal head predominantly at the level of the metadiaphyseal junction, really, and should be dead center ideally on both, on the lateral plane for sure, lateral fluoroscopy. And you have to then determine sort of, hey, are you going to aim sort of perpendicular to the first metatarsal, or are you going to aim perpendicular to the second metatarsal, depending on your deformity correction? And in terms of the distance, the tip of the actual wire itself should get to about the lateral aspect of the fibular sesamoid, because the guide is going to effectively target that. The guide is designed to effectively target the tip of the wire. And that's a huge advantage here. So the osteotomy position and pilot hole is effectively set. Once this olive wire is in, you can then slide the actual guide onto it. Once you like the position of where the guide is relative to the size of the foot, which gives you some degree of flexibility, you can go ahead and tighten the knob at the top. And after you've already positioned in your dorsal plantar plane, and once that's tightened down, then you can release sort of that aiming arm knob to go ahead and swing the aiming arm as much as you're able to get down to the level of the metatarsal flare and fire your wires accordingly. And this, in my humble opinion, is hands down one of the biggest advantages to this system, in contrast to what we've been doing all the while, and will make this fourth generation technique of minimally invasive Hallux valgus correction that much better. And so you'll see me putting the sleeves for the 1.6 millimeter K wire down onto the pseudo patient, as it were. But one thing I will tell you in particular to be aware of is that many times, once you like your positioning, you want to make sure that that sleeve is getting down to bone, because again, depending on the robustness of the soft tissue envelope, the wire itself may have a little bit of a tough time just pop into the skin without there being a small incision. So that's just one nuance to be aware of as you're trying out this technique. And so what does this look like in real time, right? So here is me getting this lateral view of this. This was a revision case, believe it or not. Obviously, you can see the previously placed cannulated screw, and no, this is not my case from before, but this is the case that I did the revision on specifically. And there is the olive wires. Sort of, we're making sure that we're as central in the head as possible. And of course, we're maybe a touch dorsal just by virtue of the fact that that cannulated screw is blocking us from being a touch more plantar. And that's something that you have to be mindful of as you are planning this. Now, of course, you have to make that decision for yourself. Are you going to be perpendicular to the first, or are you going to be perpendicular to the second? And again, thinking about the parabola of the foot, thinking about the extent of correction. Do you want to go uphill, go downhill with the translation? What's going to make it easier to get the alignment set as you would like it? So once the guide goes on, as you can see here, this is now the wires or the respective sleeves that have slid through the aiming arm itself, and I've locked that in place. And you can now see, hey, I've basically got my sleeve down onto the bone. You can see the tip of the wire just peeking out from the tip of the wire peeking out from the sleeve itself, and I'm getting ready to fire that wire. And this is sort of my technique tip. I personally like to fire the wire to as far at the level of the lateral cortex as possible. I then go ahead and check a lateral x-ray, make sure I like this wire, and then go ahead and pop that through. Because for me anyway, at least in my hands, once I've done the burr work to create the osteotomy, taking the 2.1 millimeter burr, it's usually a 2 by 20 20 millimeter length burr, I'll go ahead and complete my osteotomy through that pilot hole, and then be able to displace the head appropriately and then fire the wire across. I do think you have to be a little bit careful with perforating that lateral cortex, because if you have to start changing the wire directions and so on, you might weaken that lateral cortex. So, proceed with caution, but it works relatively well in my hands doing it that way. So once we now have, our reduction wire in place, we can see I've almost got my Brad 100 down. I've been able to advance that wire in place, and I probably could have gone even a little bit more lateral in the head if I wanted to. And I can confirm on the lateral that we're in good position with both wires that have been advanced. And this now I was able to, basically make a set of train tracks between that other screw and get 2 screws in. Again, it's a 3.2 millimeter drill bit for a 4.0 millimeter headless, beveled, non-differentially pitched screw, Pico 2.0. Make sure you ask your reps about this, proactively, because it's now out and available. And then you can proceed with your Aiken. The wire is slightly larger than it was previously. It's a 1.2 millimeter wire. And then, of course, you can close that down. And her sesamoid and her whole complex was pretty scarred in. So the rotation of the sesamoid station was maybe a little bit suboptimal, but clinically looked really, really good. And I will talk about what to do and how the Wires First can also help you with the spike in just a second. But what I will tell you is that the spike may be, again, going back to what's hard about these cases, the spike may be one of the hardest parts of the case. And so whether you're using, a very simple approach of, using a rongeur and breaking it apart and morselizing that area, which does work well, I think, in some cases, you can also use the Wires First guide as a parallel guide, as I did in this case, a separate one, and then pop in a 3.2 millimeter drill bit, pour out a little hole, and then you can go ahead and pop your burr in, complete your cut, and then excise that piece and reduce the risk of a secondary bunion from forming. So this is that patient whose case I just showed with the Wires First. This is her actually just literally at her 3-week mark, standing, walking. She's already wearing regular shoes. She hasn't really followed my exact protocol, but it just goes to show you that you can be aggressive with these patients. And I think that's a huge thing that I would share with you or anybody else for that matter, and which is an advantage of using a technique that's reproducible in this case with the Wires First guide. So this Wires First allowed us to get predictable wire placement, get the screws in predictably. Of course, the Aiken, you're still freehanding for the most part, but the point is that this system has been a game changer in my hands in making it easier for the 4th generation Hallux valgus correction that we're now able to afford, and especially in a revision case like this, that the patient was particularly painful from. So here are some other Wires First cases that I've done recently. And you can just see sort of how distal you can get, not just with the screw, but how much of that bone or that spike you can remove in order to not only reduce the risk of a secondary bunion, but also at the same time get the correction you're hoping for. Here's another case. In this case, I used a little bit of that rongeur technique and got it pretty good. I would say that probably could have been a little bit better, but the point is that this patient has done exceedingly well. I think we've moved on to their other side at this point. And these are some of these patients, right? So this is a patient that I just, patients overall doing well. Maybe, some people get aggressive with kind of smoothing down the head. I will tell you that there's no real prominence clinically. There's maybe a little bit of, you got to stare at this joint and wonder what that's looking like. That's okay. It's been looking well in all the way. And these are his x-rays. Or his clinical appearance. And if I show you his range of motion right now, and I'll turn the sound off, he's got pretty good range of motion and he's working on getting it better. And what I don't have on the video, because he was starting to have a little bit of discomfort, is I was able to get him up to, to 90 degrees. So he's working on the range of motion. He's obviously got some really well-healed scars, and he's happy as a clam, at this point, happy that he did it. And of course, in terms of the alignment, you might say, hey, maybe he's got a little bit of valgus left. Of course, we know the HPA is up to 15 degrees is normal. I like to leave a little bit of a curve, a little bit of a gentle curve, just for toe box, accommodation. But again, I'm staring at these things and thinking about that as we move into the clinical decision making at the end of the case. So here's another one recently done, and you can see sort of what the scars look like. She's probably about 2-3 months out. As one I just did a little bit ago with the Wires First, and how incredible this looks for her. And again, super happy as a clam. You'll notice the toe spacer that's here, and I use that pretty much starting from when they start moving it. So once they come in and do their first post-op check with me a couple weeks out, I get them in a toe spacer, have them start moving it, and then pretty much let them start putting full weight on it at that point itself with a flat post-op shoe. This is another Wires First that was done recently. I've already done her left side with Wires second, or sort of a Wires First guideless system, guideless approach, but did this with the Wires First guide, and she's loving it as a whole, and is back to a lot of her activities, and she's about I think she's about 4 to 6 months out at this juncture. So what have I, learned as a whole with wires first, right? I've showed you a jig. I've showed you when there's lots of jigs. I have showed you sort of doing it without a jig. And I've also, shared with you sort of, hey, what some of my colleagues are doing or have done. But I will tell you with this technique in particular, you really have to pay attention to that olive wire position. Whenever we have our team calls, myself and our entire team really harp on that because that is what's going to help set your osteotomy and likely where your wires are going to go and ultimately where your screws are going to go. Making stab incisions to get the sleeves to bone, I think, is a huge it's a real big plus because that way the wires aren't going to inadvertently skive, which can sometimes still happen, especially if the cortex is particularly thick. And that leads to, hey, thinking about your second wire, positioning it, and how you're going to shift the head, right? What sort of tool is it going to be? This reduction wire off the Pecaplasty set? Is it going, or the wires first set? Is it going to be the like a joker or some other device, or is it going to be a head pusher that you use from the Pecaplasty original guiding system? But I will tell you, no matter how you do it, you just need to really pay attention to displacing the head and making sure you're not shifting dorsally or planarly as you are going ahead and advancing those wires, because that's an important consideration too. Sometimes doing the shift in the lateral position can kind of take gravity out of the equation a little bit. The rounded nature, cylindrical nature of the reduction wires, I think also helps to limit the dorsal or plantar displacement of the head as well. And then finally, there's a parallel guide on the set, but I like also using the Wires First guide as a secondary tool to facilitate that spike removal. Just make sure you're thinking about, hey, what works in your hands? I will tell you, using a wire, getting a pilot hole with the drill, and then using the burr to cut it out can be super useful. Sometimes a raw drill can work just as well also. So on that humble note, we are at about 40 minutes of time. I want to, above all else, thank you all for being here. I want to leave it open for questions about this technique, any sort of other pitfalls or pearls that I might have. I want to thank Natasha Yusta, Megan Nayak, and the entire Enovis team for allowing me to be here today. And of course, to Beverly Williams from Foot Innovate. Thank you for this opportunity. Really appreciate being able to share this with y'all. And super excited. Again, you'll win fast with Wires First. So thank you again.
Thank you so much for your time today, Taps. We really appreciate it. Maybe as some questions are coming in, you can go over what specifically your post-op protocol is with the distal osteotomy, especially with MIS, and then as a secondary question, maybe some feedback that you get from your patients. Like, what are some of the statements that your patients have made, either about recovery faster than they thought it was going to be, maybe swelling, those sorts of things?
Yeah, I will tell you that as a whole, a minimally invasive approach has really changed how I do my post-op protocols, especially from the bunion correction perspective with this osteotomy, with the Wires First technique, and so on. Now, ultimately, what it's really dictated by is the construct, right? The two screws in bicortical fixation, 2 screws in the metatarsal, and 1 screw across the phalanx if the ACA needs to be done. So 2 weeks. So I usually keep them. Let's soft tissues calm down, see them 2 weeks post-op, and then go ahead and then I'll go ahead and I'll let them start putting weight on it fully with the post-op shoe. So they're usually in a boot till that point, at least in my hands, because I also worry about patients falling early on. They're on meds and things like that. So really want to protect everything. And so I allow them to be heel weight bearing. Once the nerve block has worn off. If they get a nerve block, foot flat with a flat post-op shoe at the 2-week mark. Start moving that toe. Stitches come out usually between 2 and 3 weeks, and then they're basically foot flat weight bearing with a regular weight bearing with that post-op shoe until about the 6-week mark. When I see them back, we kind of go over how things are going, and then transition therapy and regular shoe wear at that point. I will say that patients as a whole, on average, love this. There's definitely some folks who have neuritic pain, usually from branches of SPN. There's some patients who have just, more swelling than others, but swelling is definitely decreased as a whole, especially the more that they can start moving earlier on. I would say pain, medicine consumption goes down pretty dramatically, especially after about the first week to 10 days, at least with my patient population. And of course, they're just happy. They're happy that they it's not what they heard from their, grandparent about what bunion surgery was like. They're appreciative of sort of what it looks like clinically and as well as on the x-rays. And ultimately, the question that comes up usually by around the 6 week mark is, when can I set up the other one? And that to me is a real telltale. If the patient is inherently their own referral system, and then they're also telling family members about it, then that's a win. And whether we're winning with Wires First or we're winning with patient outcomes, ultimately we want to win together. And that to me is perhaps one of the best things about being able to not just do this surgery specifically, but also to use this technique.
Sure. No, that totally makes sense. Could you also talk a little bit about if you've seen any reduction on fluoro scans by using the Wires First jig, and kind of how that's affected your OR time and just kind of your perspective on that?
Yeah, I would say as a whole, in terms of wire placement, it's definitely reduced the time. It's cut it down, and especially I let the residents do a bunch, or try to let them do a bunch, with the wire firing and so on, especially kind of working the jig. But I will say I'm also just super neurotic, and super neurotic about what I do in the OR, and really because we're still, it's released, it's out, it works well. I also am particularly paying attention to the jig, the positioning, all of that, where the wires go. Would some of the wire positionings be acceptable and be okay? And then I'm futzing with it a little bit more because of my own neuroses? Absolutely. So do I think I could probably shave some time off if I wasn't so neurotic about everything, this early on into the launch? Probably yes. But I would say that I want to make sure I'm doing my best for the patient. So I do sometimes spend a little bit of extra time. However, I will tell you that as a whole, in terms of getting through it and it's getting those wires in as optimal position as possible, it hits the mark pretty darn consistently. And any sort of additional messing around is just because of me, myself, and I.
Got it. Well, I appreciate all the time that you spent with us today. The videos and everything were so helpful. I hope it was helpful for the audience. Again, thank you for being a part of this and for being a part of the Enovis team. And thank you everyone for attending the Wires First webinar this evening with Foot Innovate. Any last words, Tabs?
Yeah, I'm just going to go to my last slide. For those who have questions about this or anything else for that matter, I really just want to feel free to reach out. So obviously my contact info here. We can't do opportunities like this aren't don't happen every day, and it's really special to be able to do this with you, Natasha, the entire Enovis team, and of course the SAB members at large. And so I really want to thank everybody for the support and for this opportunity. But as it relates to the technique, check it out, try it out. It works well. I'm not just saying that, it genuinely works well. And I think that what we have seen of people who have been testing it themselves, really appreciate the fact that it's radiolucent, the fact that it's not bulky, the fact that it doesn't require a lot of attachment, as it were. It keeps it simple and predictable, which is hands down one of the best things that will reduce that pain point and hopefully take off or hopefully add to that wish list hopefully reduce the number of items on that wish list.